It's 2:30, so we're going to get started with our webinar. I'm sure you all have lots to do, so we'll see how we go. I just wanted to let you know as a reminder that this work receives support from the CC Canada funding from the Canadian Institute of Health Research. And we are going to get started with a webinar about psychological depression prevention programs for 5 to 19-year-olds. And thank you to Kathy Moran at Durham for connecting us with the appropriate participants. I'm going to fast forward to a housekeeping slide. These are just some announcements. First of all, happy Valentine's Day to everybody. If you love technology, hopefully it's working for you today. If not, this housekeeping slide shows the WebEx 24/7 helpline. It's 1-866-229-3239. And Yasso has also typed that into the chat box so that you can read that on your screen. She's given some instructions for testing your audio if you've just come on the line. If you're still having any technical difficulties, that helpline is the one to call, and they can usually help pretty quickly over the phone. If you love hockey, maybe you know by now that Canada beat Austria in hockey 6-0. If you love figure skating, Hetrick won a silver today. So that's my Olympic update. I'm a little bit addicted. Now we'll get to what you're actually here to hear. The housekeeping is that we'll ask today that you use the Q&A in the chat. You should see at the right side of your screen to post any comments or questions during the webinar. I'm going to be reading those and trying to get them as they come in, but rest assured that Yasso is there to make sure that I don't miss anything. So there are 2 of us watching for those, and if we're kind of on a roll with the discussion, we'll make sure that we do get back to a question at some point. Might be a little bit later, but we're going to watch for those and make sure we check them all off our list by the end of the call. If you can send the questions to all and not privately to the host, that'll be a big help. The reason for that is so that both Yasso and I can see your questions and we can make sure that I don't miss anything while I'm speaking. We recommend today that you use a wired internet connection versus wireless. That just helps prevent any connection problems. That's something that's happened in the past. So if you're all at work today at Durham and you're at a PC, you're probably fine. Some very brief introductions. This is some photos and names of the health evidence team since we can't see you all. There's Maureen Dobbins, our scientific director. I'm the managing director. And there next door to me, there is Heather Hudson, the project manager, Robin Trainer, research coordinator, Lori Greco, knowledge broker, and below us, Yasso and Kelly. And Yasso is also on the line with me today, and Yasso's been managing these webinars. So thanks, Yasso, for getting us all organized and setting things up. I just wanted to go over briefly what is healthevidence.org. I know some of you may have heard of us before, but if it's the first time, then I'll let you know what we do. We have an online registry of effectiveness evidence in public health. So we've gone out and collated all of the systematic reviews on the interventions in public health that look at effectiveness and brought those together in one place. So it's free and searchable online. What you get in your results is the list of reviews, and you also get a quality score. So 2 of our staff members have gone through and reappraised all of the reviews that we have, so you can see the quality score, and hopefully you can save you the time of having to do the critical appraisal yourself. Why you might want to look at healthevidence.org is that it does save you that time of doing the searching, locating articles, critically appraising them. You can find all the review level evidence in one place, so you don't have to sift through a number of articles to decide what to review for a single study. Looking at reviews means that you'll save time just by the nature of the evidence, because a review brings together all of the primary studies around a single topic. So today we're looking at a review that brings together all of the single studies around depression prevention for 5 to 19-year-olds. Health evidence is all relevant and current evidence in public health. We've outlined our process online, so you can read about the process, and then if you feel that you're comfortable with the process, you can just go with the quality rating and not even have to do that work yourself, providing you agree with our criteria. We have supports for EIDM available, so there are some tools online to help make decision-making easier and support decision-making, and I know that you have some in your policy and procedures manual, so those are really consistent with the supports that we have online, and it's likely very much the same as what you would already see in your policy and procedures. So you don't have to worry that we're speaking two different languages. Health evidence is also easy to use. If you have a problem while you're using it or you're having trouble searching, you can contact us through the contact us link on the site. That goes to 2 staff members, and we try to reply as soon as we can, but usually within 1 business day. So today we said that we would be using research evidence for decision making, and we're using the term evidence-informed decision making, or EIDM. And what you see in front of you on the slide right now is the model for evidence-informed decision making. So this model just acknowledges that research evidence, that purple bubble, is one of a number of factors for decision making. So we're just advocating for research evidence to be consistently considered in decision making, but not necessarily that it's the end-all and be-all and a main factor that would make a decision. You also have public health resources, community preferences, and political preferences, the local context, and of course very central is public health expertise. So if we had a fancier version of this model right now, we'd be able to show you that these bubbles change in size relative to each other, and sometimes certain factors might become more prominent and maybe the deciding factor in a particular situation. So all this model suggests is that research evidence be consistently considered as one factor. When we talk about evidence-informed decision-making, we're aiming to advocate for a few different things to happen. We want people to generate a culture of inquiry and critical thinking and practice that's based in evidence, informed by evidence. And this involves asking clear, focused, searchable questions. So in your policy and procedures manual, you have assistance with developing a PICO question. Searching for the best available evidence is next, and we suggest that you'll want to search healthevidence.ca for effectiveness evidence, specifically because we already have review-level evidence that have already brought together all the primary studies. It's free of phrase, and it's all relevant to public health. Last, we have critically appraising the relevant evidence. So this is something you would generally need to do, but if you're using healthevidence.org, that evidence is critically appraised for you, and you'll see a quality score. So the score will be weak, moderate, or strong, depending on how it rated on a tool that we use to assess quality, and those criteria go from, if articles can score from 0 to 10. After critical appraisal, there's synthesis and integration of the evidence with expertise, the local context, and client preferences. Implementation and, of course, evaluation of the outcomes, and then engaging in knowledge exchange to share what's learned from that. So today we're going to apply the EIDM process to a review by Mary from 2011. This is published in the Cochrane database of systematic review. So this review is on psychological and/or educational interventions for preventing depression in children and adolescents. And what you see in front of you right now is the full review reference. So you can see this is how you would go to the database of systematic reviews to order the full article. We also have a summary statement that this is based on, that the webinar is based on, where we've taken a summary or a snapshot of the review and given you the bottom line in a much shorter version. Just some facts about why we would want to pay attention to this review. The burden of depression is quite high, and the WHO estimates that it's the largest burden of disease to Canadians older than 14. And, you know, I don't have to convince all of you of the severity of the issue. We know that high stress levels and feelings of depression are more common than in any other, for 18 and 19-year-olds than in any other age group, and this review goes right from age 5 to age 19, so carries through that age group, 18 and 19-year-olds. So I just wanted to run a brief poll. We have some polling questions, and you'll see the poll available on the right-hand side at the bottom of your screen. So I'm just wondering, I talked about identifying a searchable question, and I mentioned PICO. Who's heard of a PICO question before? Just a yes or no question. So it looks like most people have heard of PICO, so that is something that's familiar, which is good news. Everybody's reading the policy and procedures manual or using health evidence already. Just as a quick recap, this is what PICO represents: population, intervention, comparison, and outcomes. So when we think about this review in particular and the evidence summary, we're looking at whether these interventions are effective in preventing onset of depressive disorder in children and adolescents. So breaking this review down into a PICO for this question is looking at the population of children and adolescents aged 5 to 19. The interventions included in this review were psychological and or educational programs, and that includes either targeted or universal. The comparison was placebo or any other comparison intervention. And the outcomes of interest were prevalence of depressive disorder and depressive symptoms. Just some overall facts about the review. As I said, we rate all these reviews on a scale from 0 to 10 using standard systematic review quality criteria. This review rated a 10, which is strong. So it's a very well done review that's based on 68 randomized controlled trials of moderate quality. So the trials that fed into this review are of moderate quality, which is not bad, and then the review itself is really methodologically strong. So the review authors did a very rigorous job of pulling together these 68 randomized controlled trials. The bottom line from this review is that psychological and educational interventions are effective at preventing depressive disorder, for the first outcome, and also for reducing depressive symptoms for children and adolescents aged 5 to 19. The effectiveness is maintained for up to a year post-intervention, and there's not a huge amount of data about the longer-term impact. So the good news is that this effectiveness is maintained right immediately post-intervention at 3 and 9 months, and then 12 months post-intervention. So up to a year post-intervention, we know this is still working. In terms of targeted versus universal interventions, there was a similar level of effectiveness for both, up to 9 months post-intervention. Only targeted interventions showed effectiveness at 12 months. And for this review in particular, they tried to look more long-term, and no effects were shown to persist beyond 24 months for both targeted and universal interventions. So far for these psychological and educational interventions, they haven't been able to show effectiveness beyond 24 months. Just to recap the type of evidence that's behind the two outcomes of interest in this review, as I said, there were 68 total RCTs included in this review. For the diagnosis of depressive disorder, that involved a total of 16 randomized controlled trials. So when we think of levels of evidence, even though today we're talking about a single review and one article, that one article brought together 68 studies. And for this particular outcome, diagnosis of depressive disorder, when they pooled the relevant studies, 16 randomized controlled trials around that outcome, that represents data from over 3,000 subjects, so 3,240 subjects. In terms of the second outcome around depression scores, there were 55 RCTs that were relevant to depression score outcomes for psychological and educational interventions. And so the data from this single review involving 55 RCTs for that outcome represents over 14,000 subjects. So just a reminder of kind of the bird's eye view is that even though it's a single review, when we really drill down further, we can see that there are a larger number of trials and an even larger number of subjects represented in a review. And that's one of the strengths of a systematic review compared to a single study. If we looked at any of those single studies, it would represent the data for many fewer participants. So for the first outcome around diagnosis of depressive disorders, what does the evidence tell us? Compared to no intervention, those participants who were part of the intervention groups had a very small, statistically significant reduced risk of depressive disorder. So there was risk reduction that was actually statistically significant, even though it was a small difference. So the reduction was small, but it was still there. And we say that it was small and it was statistically significant. The decision remains to think about whether that's clinically significant. So even though it's a small difference, it may be clinically significant and an important difference to be able to make. So that difference showed up immediately post-intervention, also at 3 to 9 months and at 12 months. So the difference was sustained up to a year after the intervention. Also, the intervention was, the risk reduction was sustained with both targeted and universally applied interventions at 3 to 9 months. So up to 9 months after the intervention, it was, between both universal and targeted interventions, both showed benefit. However, a year post-intervention, only the targeted interventions with high-risk subjects showed a significantly reduced risk. So at up to a year, to show a difference at up to 12 months post-intervention, only targeted interventions were effective. They looked longer term, so further down the road, at what was the risk at 24 months. There were 8 studies that measured that distance or the risk at that long-term point, so longer than 12 months post-intervention. So what was the risk 2 years after the intervention? There was no risk reduction there, but a very small statistically significant risk reduction at 36 months. So even though overall the studies that were involved in this review weren't able to establish a clear, very long-term risk reduction that was stable at 24 and 36 months, the fact that there's that very small statistically significant risk reduction at 36 months gives us some hope and gives us some implications around the long-term nature of the intervention that's needed. So that was all around the first outcome of depression diagnosis. Now we're going to talk about the second outcome around depression scores. So this is what the data behind what the review said around depression scores. So again, compared to no intervention, intervention participants showed a small to a very small statistically significant decrease in depression symptoms. So symptoms were decreased, but the reduction was very small to small. So there's a range, and it wasn't a huge reduction. But again, the decision around clinical significance needs to be made. When we look at the evidence on depression scores from this review, there was no impact on depression symptoms at 24 months and 36 months. So there were studies within the review, 12 studies at 24 months and 5 studies at 36 months, that looked at longer-term depression symptoms and change at 2 years and 3 years post, which is great. And there was no impact demonstrated in this review. There was no impact on depression symptoms post-intervention when the intervention was compared to a placebo. So when the intervention was compared to no intervention, there was a difference. When it was compared to a placebo intervention, there was no difference. Then thinking again about targeted versus universal types of interventions, because that's often a big question. Interventions targeting the high-risk individuals and those that were universal showed a decrease in depression symptoms from immediately post-intervention to 9 months post-intervention. So this is the same pattern that we were seeing with the diagnosis of depression, right? There were differences, there was no difference between targeted versus universal up to 9 months. And then at 12 months, only the targeted intervention showed a decrease in depression symptoms. And there was no decrease at 24 months. So we've been able to see that targeted interventions have shown a decrease in depression symptoms up to 12 months post-intervention. We don't have evidence beyond that. So what's the bottom line, and what should public health do as a result of these studies that have been summarized in this review? The general bottom line is that public health should provide psychological and educational interventions to prevent depression up to 12 months post-intervention. That's how far we have outcomes to demonstrate that it works. Public health should not expect children and adolescents to experience positive effects of interventions more than 12 months after intervention. So Beyond 12 months, we don't have evidence to show that there would be positive outcomes, so expectations need to be in line with that. Last, public health should consider how the effects of psychological and educational interventions can best be maintained. So we would ideally like to see those positive findings sustained beyond 12 months after the intervention, and more needs to be done to find out how to best maintain those so that we can see changes at 24 months post and 36 months post and beyond. So that's just an overview of the content of the review, very much the bottom line. We have a link to the review on the website, and I believe that you would be able to get access to that review through your library. So I know that you may not have time to read the full review. There's probably a lot of reading material on your desk, but those are the main findings of the review, just to let you know what they are and let you know whether it's something you need to look more closely at. So I just want to open the floor to questions right now to see if there are any questions, and you can type those into either the chat or the Q&A, and just try to direct your query to all. See that Yasso has posted the link to the summary in the chat. And we can also do the 2 remaining poll questions while we're waiting. So we just had a couple of poll questions, and I want to give you a chance to answer those, but also think about whether you have any questions about the review. Feel free to ask general questions too about health evidence. I should be able to answer those. And I'm happy to do that, or questions about the method. If there's anything I went over that wasn't really clear that it was, if you want to ask about a definition, that's fine. Anything that can help improve the clarity. And just to give everyone a heads up before we start the poll, there is going to be an evaluation survey at the end. It's really quick, I promise. And the evaluation survey link is going to go out immediately following the webinar. So when you close the webinar, you should have a link to the survey, and we'd really like to get your feedback just for a couple of minutes. This KP Canada funded webinar is being evaluated. So this webinar series is being evaluated in terms of small group versus large groups. So we have some people attending in a small group from a single health unit, which is the case today. You're all from Durham. And then we've had some larger group webinars, and we'd like to be able to compare. So any questions today? Was everything absolutely crystal clear? Also find all of our names and contact information next to our pictures on the website. So you can go to healthevidence.org to see us and to find us. Then there's a location there, a link where you can find a copy of the presentation. So if you have a colleague who wasn't able to attend today but who might be interested in the content, so the slides and with the audio recording, they can go to our webinar page and be able to hear the webinar themselves. And you need to log in with your health evidence username and password or register if you aren't a member yet. So just something to note that we do require a login on the site, but login is free, and once you're registered, then you can change your personal settings and log in again. I see we do have a question in the chat. The first question is whether we're able to be more specific about psychological interventions. So the psychological interventions included a range of things. They did describe them in the review, so I'm just going to go to the review to get you a more detailed definition. And there is a pretty good outline in the review. The good thing about Cochrane reviews is that they do give a lot of detail really consistently across all the studies. So when you go into a Cochrane review, even if you're not, even if you don't find the level of detail you would like in the interventions description in the method section, you can actually go all the way into the detail from the table. So it breaks down all of the study details in tables. And those will really give you the blow by blow for individual studies. So the prevention programs that they talked about in the review were really varied, as well as the components that they included and the focus of the components. So I'll just give you kind of a rundown of some of the major strategies that were listed as components of the interventions that they included. It said that most programs included some components of CBT, so cognitive behavioral therapy. Others included a focus on self-efficacy, stress reduction, trauma, or optimism. Some programs were gender-specific, and some focused on family members. Some were school-based, while others were online or based in primary care settings. Many were group-based programs. So a lot of them were group-based cognitive behavior therapy, and there were also a number of other specific prevention programs that were named in the review. So I know that you probably do really know the names of these programs, so I'll give you some more information from the review. And so I'm just looking at the full review now. There were a number of specific programs. So 11 of the studies used programs developed at University of Pennsylvania. So the original PEN prevention program, and then there was the PEN resiliency program, PEN optimism and life skills program, and the PEN resilience program for children and adolescents, then combined with a parent component. One study used Mood Gym, and there was another web app, so web-based management of adolescency, coping with stress course, teaching kids to cope, stress inoculation model, a whole host of others. So there's a very long list of individual programs that were all pooled, and it named the programs here. Others that were not so formal, so they weren't part of a program that were named, stated that they were based on cognitive therapy. There was one that was a peer support program, another that used play therapy, and another one used brief trauma therapy and psychoeducation. So it goes on to talk about the studies. The programs were delivered by clinicians in 40 studies, so most of them by clinicians, by teachers in 10 studies, by trained facilitators in 7 studies, and by teachers and counselors in 2 studies. So of the few that remain, 2 studies were computerized and delivered by a web-based program, and 1 also used the support of teachers. There was only 1 study that didn't give any details on program facilitators, so out of the 68, only 1 didn't make that clear. So is that helpful in terms of level of detail? There is quite a bit of detail in the review itself. I see that YASO is also giving the location within the review, so a list of the interventions can be found on page 10 of the review. So I see that Kathy has also asked a question. I'm interested in the last recommendation that public health should explore the effects over a longer period, given the evidence why further research might be needed. I guess there's interest, even though this intervention looks like it works, it makes a difference up to a year post, which is great. They're still interested in knowing how long it can be sustained. So how can we get things to be sustained longer? And I do know that there's not all the studies measured effectiveness that long term. So a lot of it is being able to do measurement longer term. Any other questions about the review? This could be about the methods of the review. It could be about health evidence in general. I'm just checking the Q&A in the chat just to make sure I'm not missing any questions. We're going to ask you some questions in the survey, and the survey will be really brief. So I'm going to, if there are no more questions, I'll let everyone go to do that so that you can spend your time on the survey. We did want to make this as succinct as possible so that you can get back to the work that you have to do. And sure, it looks like there might be one more question coming, so we'll just wait for one more question. We'll be on the line, and then the survey will go out. But just to note that if you have any feedback or comments, feel free to email us with the info address on the screen. So there's a question about the educational intervention and what were some common themes. So I'm just taking a look back into the review to find out about that in the overview. It's giving an overview of range of the studies and the sessions and the comparison of the comparator group. So this is exactly the thing that we advocate for when we work with health units. Really just going over the summary and this bottom line only makes you ask more questions and have to go back into the actual review. So a summary statement by no means keeps you from having to read the review. There's always more questions, and certainly the level of detail that you get from a summary statement wouldn't tell you everything that you have to know. So I'm just taking a look back into the types of interventions to see what I can get detail on with respect to the education interventions. So they're talking about inclusion criteria. So they included psychological interventions as those that target psychological processes, and educational interventions were those that provide education about depression, its causes, and what could be done about it in a broad sense. So anything from a lifestyle intervention, like advice on nutrition and lifestyle, and they indicate that the two may overlap. So they don't give a huge amount of detail on the actual educational interventions, but I think that would be in the tables of the review. So while they haven't given us an overview of the themes in the educational interventions, I think it's likely that they're in the table. So in the Cochrane review, when you go to the end of the review and they have the tables, they're very long depending on how big the review is, you can read about the actual interventions themselves. So if we go to an example of an educational intervention, just looking through them, and most of them are psychological. Psychological. So just looking for an example of an educational intervention. and delivered by 2 trainers who were counselors working in education. And it looks like it was a 3-day class around lifestyle and life skills. I'm just checking to see if there are more examples. So the psychoeducational intervention focused on psychoeducation and general skill building, and it had 10 90-minute sessions. So it looks like there was quite a range of what was involved in the sessions. And they used therapists who were master's level psychologists and social workers. And that was delivered by a school guidance counselor and a social worker. So that program was called Teen Talk. It looks like it's a huge variety. If you're really interested just in the education intervention, you probably would want to go through the actual table in the review. And YASO has pulled out that there were 50-minute 50-minute lectures developed by health education teachers, a 15-hour workshop delivered over 4 to 5 days from vocational institutes, lectures developed by psychologists. So it looks like there was quite the range in terms of the number of sessions, the intensity of the intervention. So I hope that helps a little bit, but certainly this is one of those situations where it would be good to go to the review and pick apart the educational interventions that were in the table and pull those out to see whether those details are similar to what you're doing or are the type of educational intervention that you would expect when you just read that general term. Definitely illustrates the importance of going back into the review. So I'm still not sure I answered the question about what were common themes in the educational intervention because I'm not sure that we have the level of detail for the content. So beyond just going back into the review, if you really wanted to know what the themes were from the individual studies in the review, you'd probably want to find the educational intervention studies and then actually go into the single studies themselves to get the details of that intervention. And I know that seems like a lot of work, but the reference list is there, and it's actually not bad to retrieve the single studies when you already have the reference. It's not a high number, and you can usually go to the ones that were most well done because if the review has done a good job, it affects the quality. So you can go to only the most high quality education studies and then check out a more detailed description of what was done to see if you can actually extract detail on themes. So there's been another question around differences in depressive disorder scores and whether the difference is clinically significant. So this is a pretty subjective question about clinical significance. And typically the way that we would assess that, and when you're applying this in practice, this is, how you would make a decision, thinking about the confidence interval that's presented and thinking about whether you would make the same decision at both ends of that confidence interval and thinking about the size of the difference and whether that makes an important difference in your population. So although I don't think I can provide an answer about whether a difference is clinically meaningful across the board, if it were the case that a small difference was any difference was desired, then I think the size of this difference, even though quite small, might still be clinically meaningful or clinically relevant. So I would still consider it clinically relevant, and it just depends on, I guess, the goal and how big a difference you feel that you need to make in the population. So I think that there's no across-the-board answer to this, but thinking about the range and what you might expect and whether or not you feel that even a small difference is clinically meaningful. So I hope that's helpful. I know sometimes it's not ideal to hear an answer like it depends. But some of it is a bit subjective and taking into account the local situation and what the difference is, whether that difference is meaningful there. Any other questions? I don't see any other questions right now in the chat or the Q&A. I don't want to discourage other questions, so stay on the line, but we are going to send out a survey link for the evaluation and would appreciate any comments that you have. You can also feel free to type them in the chat or the Q&A, and you can also email them to the info@healthevidence.org address. So we'll be sending out a survey participation link. I know the survey link also asks if anyone would be willing to be interviewed for the study that's going on to evaluate the webinar. So if anyone has time for a brief phone interview, that would be really very much appreciated, and yes, I would contact you to schedule that at your convenience. So I'll wrap up for now. Feel free to email us. Please do the survey, and Kathy has our contact info as well if you'd like to get a hold of either of us individually. So thank you very much for your time today. Thanks for participating, and I hope some of this was useful to you in your work.